Okay, let's go with the disorders of the adrenal cortical function. Okay, so in relation with the dysfunction of the adrenal glands, we will focus in the most common disorders of the cortical part because the medulla produces adrenaline and noradrenaline. That's is also produced by the sympathetic nervous system, and the lack of these hormones is almost impossible. Let's first do a quick review of the adrenal glands and their products. Just take a quick look at the map. Do you know? So you know where we are, right? So first column, this second column is for the medulla. We won't review. So the adrenal glands are on top of the kidneys and are very tiny. The medulla secretes adrenaline and noradrenaline that is also produced by that sympathetic system. So let's forget about them now. The cortex, which is the outer layer of the gland, produces glucocorticoids, mineralocorticoids, and adrenal sex hormones. Do you remember which is a neurotransmitter of the parasympathetic system? Okay, review that. All right, so the main hormones of the cortex are aldosterone, cortisol, and androgens. Yeah, also for women. All these are steroids, which means we need cholesterol to build them. So cholesterol is not always bad, as you see. ACTH, produced by the anterior pituitary, controls the secretion of cortisol and androgens. If you remember, aldosterone is part of the renin-angiotensin-aldosterone axis, and renin is produced by the kidneys in response to dropping blood pressure reaching the kidneys. All these adrenal cortical hormones are metabolized by the liver and then eliminated in urine or bile. Androgens produced by the adrenal glands are especially important for women. Men have their main source coming from the testes, so they are not so dependent on the adrenal glands. In women, these hormones are responsible for growth of axillary and pubic hair, as well as sex drive in adulthood. As said before, aldosterone is secreted in response to renin production by the kidneys and is important in the regulation of sodium and potassium, which are very important electrolytes. Remember that sodium movement drags behind water movement, so it also affects water balance. Cortisol is known as the stress hormone. It regulates multiple metabolic functions as well as inflammatory and immune responses. Since cholesterol has a negative feedback on the release of ACTH, and this hormone normally peaks in the morning and declines as the day progresses, altering the sleep pattern, like when working at night, also alters the release of ACTH and cortisol. Other factors like stress or psychological disorders may alter the rhythm of release. Here you have some of the effects of cortisol, but let's go on because we will widely review these in the coming slides. Alright, this image shows the adrenal gland with the hormones it produces and their effects. Now let's go with the disorders, starting with hyperaldosterism. Alright, so hyperaldosterism refers to an endocrine disorder where the adrenal gland produces above normal levels of the hormone aldosterone. Now, there are two adrenal glands. one above each kidney, and each one has an inner layer called the medulla and an outer layer called the cortex, which is subdivided into 3 more layers: the zona glomerulosa, the zona fasciculata, and the zona reticularis. The outermost layer is the zona glomerulosa, and it's full of cells that make the hormone aldosterone. Aldosterone is part of a hormone family or axis which work together and are called renin-angiotensin-aldosterone system. Together, these hormones decrease potassium levels, increase sodium levels, and increase blood volume and blood pressure. Aldosterone is secreted in response to elevated levels of renin, and its role is to bind to receptors on 2 types of cells along the distal convoluted tubule of the nephron. First, it stimulates sodium-potassium ion pumps of the principal cells to work even harder. And these pumps drive potassium from the blood into the cells, and from there it flows down its concentration gradient into the tubule to be excreted as urine. At the same time, the pump drives sodium in the opposite direction from the cell into the blood, which allows more sodium to flow from the tubule to the cell down its concentration gradient. Since water often flows with sodium through a process called osmosis, we'll review that in the first year, water also moves into the blood, which increases blood volume and therefore blood pressure. The other function of aldosterone is to stimulate the ATPase pumps in alpha intercalated cells, which causes more protons to get excreted into the urine. Meanwhile, ion exchanges on the basal surface of the cell move the negatively charged bicarbonate ions into the extracellular space, causing an increase in pH, that is alkalosis. If there is excessive release of aldosterone, a condition known as hyperaldosterism, these physiologic actions will have multiple consequences. So hyperaldosterism leads to hypokalemia, which is low potassium levels in the blood, as well as hypernatremia, which is high sodium levels in the blood. With more sodium around in the blood, water moves into the blood vessels, which results in a high blood volume and high blood pressure or hypertension. And finally, the loss of protons also results in alkalosis, and more specifically a metabolic alkalosis, since it's caused by the kidneys. Individuals with hyperaldosterism typically develop hypertension-related symptoms like headaches and facial flushing, as well as hypokalemia-related symptoms like constipation, weakness, and potentially changes in their heart rhythm. Hyperaldosterism can happen due to primary causes, which is where the adrenal gland itself is responsible for the excess production of aldosterone. The most common primary cause is called idiopathic hyperaldosterism, because the zona glomerulosa has an increased number of cells secreting aldosterone, but it's not really clear why this happens. The second most common cause is called Conn syndrome, and this is where an adenoma or tumor in the glandular epithelial cells secretes too much hormone. A third cause is familial hyperaldosterism, and this is a genetic condition that runs in families, and it's when the zona glomerulosa they inappropriately make aldosterone in response to adrenocorticotropic hormone, which is secreted by the pituitary gland. And this is in addition to responding to renin as normal. Alright, so hyperaldosterism can also be due to secondary causes, where the pathology lies outside of the adrenal gland. And these secondary causes of hyperaldosterism are usually due to excess aldosterone production in response to high levels of renin. This might happen when there's a chronic disease in chronic decrease in blood pressure, like in congestive heart failure, or also in cirrhosis. The diagnosis of hyperaldosterism is mainly done by measuring the levels of renin and aldosterone. In primary hyperaldosterism, the main problem is that zona glomerulosa cells secrete high levels of aldosterone, and that aldosterone has a negative feedback effect against renin, and so it actually inhibits renin production. So in this case, aldosterone levels are high and renin levels are low. In secondary hyperaldosterism, on the other hand, the main problem is that there is too much renin produced by the juxtaglomerular cells of the kidneys. So even though aldosterone is inhibiting renin secretion, so aldosterone is inhibiting that secretion, but the renin production is still being stimulated by these other cells, and that means that there's both high levels of aldosterone and high levels of renin. About the treatment of hyperaldosterism is usually with potassium-sparing diuretics, especially spironolactone, which is competing to bind to the receptors of aldosterone, and these receptors, I don't know if Enrique explained that, but those are in the alpha intercalated cells. With these medications around, aldosterone can't exert its effect because the receptor is blocked by the medication. Additionally, treating the underlying cause can be helpful as always. For example, if you have Cone syndrome, surgical removal of the tumor can help, and also managing the heart failure and cirrhosis will help to address this problem. Okay, so thank you very much for listening. We will continue in short.